due to poor quality or inappropriate pharmacokinetics, meaning you picked something that should not have been used in the first place. And so the example I'm showing here is compounded preparations. These would be classified as medication errors. What I'm showing you here, and you can't see it real well, and I can't step away from it. Let's see, I can use the mouse. So this is a quote-unquote generic ulcer guard. That's what the compounding facility is calling it. It's not generic because it's not approved, so it just speaks to the fact that the compounding pharmacist doesn't really understand the laws either. But more importantly, it turns out that this drug requires a pH balancing, and this drug was in widespread use in its compounded version because it was cheaper compared to the commercial product, and this was about 10 years ago, and a lot of horses developed ulcers. So that's an example of therapeutic failure. For those of you that are familiar with transdermal gels in cats, that's another product or another compounded system that frequently results in therapeutic failure. One of the problems with therapeutic failure is recognizing it. How would you know that you have an adverse event that reflects therapeutic failure? Because we'll just assume that the patient's disease hasn't responded. So to me, that's among the most challenging adverse events to recognize. Your patient has failed therapy because of something that you did wrong. Now, of the dropping down improper exposure, what do you think is the most common reason for a medication error? Wrong dose was given, wrong drug, wrong interval, wrong patient. Which of those do you think is more common?
Wrong dose.
Wrong. So how many say wrong dose? Okay. How many of you say wrong drug? How many of you say wrong patient? Okay.
I think the first two.
So this is just a compilation of data that was done in human medicine. Again, somewhat outdated, but you can see 4 different authors. And so what they did is they said the percent, they listed the percent of errors that reflect one of the 4 things that we just talked about. And you can see by far the wrong dose is the biggest reason for this. And it depends upon the drug, but sometimes you can give 3 times the dose and you're not going to impact the patient. But some drugs you can't give more than 2 times the dose without getting in serious difficulty. And of course, not included here would be the animal is extremely sensitive. That is going to be a type A adverse event. And then over here, wrong drug or patient is also responsible for quite a few, and unfortunately wrong route as well. And if time permits, I'll show you a couple of adverse events where that is true in veterinary medicine. So let's look at some causes of medication error. What is wrong with these pictures here? What's the problem here with these medications? They look alike. The labels look exactly alike. And so it's okay if the drugs aren't toxic, but you know, if you give a little bit of epinephrine, you've killed your patient. Okay? So what can you do to prevent that? Yeah, change the label, maybe put them in different places so you're not apt to reach for the drugs at the same time. Okay. So what's right about this? Carboplatin is very safe. Cisplatin will kill a patient silly. And they're both anti-cancer drugs. What has been done here to try and minimize the risk of a look-alike?
The color of the bottle.
Color of the bottle is different. Okay, good. What else? The tall man letters. So tall man lettering is one of the ways that the United States Pharmacopoeia has helped the FDA compel manufacturers to try and make a difference to you as the user. And remember, most of these laws are written for human medicine, and most of them are for the nurses, because the nurses are usually the ones administering the drugs, not the physicians or the pharmacists. So that's been very, very helpful. Cisplatin, not only tall man letters, but they're in red letters as well. So what else is nice about cisplatin? And we see it with this vercuronium bromide, which will kill a patient because of paralysis. What else is happening? What do you see on this? We actually have warning labels now. And what the FDA and the USP have done is they've said you cannot put warning labels except on certain lethal, potentially lethal drugs. So they've limited where those warning labels can go to avoid the boy who cried wolf sort of thing. You know, if you see too many warning labels, you'll start ignoring them. So now they're very limited in where they can go. And not shown here is on the ferrule, the cap here underneath the cap. They are even more restrictive, but for some drugs like potassium, if you give IV potassium too much, you'll kill the patient. They'll allow a warning label on that actual cap so that when you pop it underneath that cap, you will see that warning. Okay, so what's wrong with this picture? Now these are veterinary products. This is Domitor, this is Dexdomitor, this is anisetin, and this is Dormacetine.
The names
Sounds
all
very
sound the
familiar.
same.
The
except for
names
Anacin.
all sound the same. So antecedent is the antidote for Domitor. A veterinarian might think that dormicedin is the antidote for dexdomitor, but it's not. This is just another dentomidine. And so you may be thinking you're given an antidote because you're supposed to give an equal volume here, and so it would make sense to pick this up and give an equal volume to reverse this. So that needs to be changed. So this is in Europe, UK. What have they done here? They've changed the bottle, they've changed the color, they've highlighted the beginning names as well. All right, so over-the-counter drugs. You need to understand that over-the-counter drugs, they are approved, but the over-the-counter drugs are treated a little bit differently, and the name, the active ingredient, may change. The name is protected, the company will keep the name, but they may change the active ingredient, and that was demonstrated when Pfizer purchased Pepto-Bismol. Now, Pepto-Bismol has bismuth subsalicylate in it. What does salicylate sound like? What is salicylic acid? What is the common name of salicylic acid?
Aspirin.
Aspirin, that's right. So that's not an innocuous drug. Aspirin will kill cats, and we can use it in dogs, but you still have to be careful because it's a non-steroidal. So what they did is they also owned kaopectate, so they just made it kaopectate. And now there are 4 different kaopectates, but the actual ingredient of the kaopectate varies. And the one that's pink, the one that I thought would be the one that contains Pepto-Bismol, actually doesn't contain anything. The one that contains Pepto-Bismol is now blue. And then there's one that prevents gas, which my pug definitely needs, and then one that prevents just regular diarrhea. So the point is, you need to tell the client to read the active ingredients. Over-the-counter antifungal agents, they may change from clotrimazole to meconazole to terbinafine. So you need to, and that may not be important to your client, it may not be important to you, but if you have a preference of one over the other, that may be important. So it's not just a safety issue, but it's also an efficacy issue. So other examples. So these are 4 different insulins. This is human Lantus, this is Vetsulin, this is PCI Vet, and this is Prozine. These are all used in animals. 3 of them are approved for use in animals. These 3. Now, look at these syringe cases down here. What's the difference, not syringe cases, but what's the difference between this syringe and this syringe?
The units.
This has 100 units, this has 40 units. Which one should be used in veterinary medicine?
The 40 units.
The 40 units, okay? The problem is if your client is using the Lantus, which is a 100 unit, a human product, then the pharmacist may send them home with this, and unless the client has been counseled appropriately, they may, by mistake, if they're used to using this, may give a full syringe full of this Lantus insulin, and that will potentially kill the patient because of a hypoglycemic attack. The other problem with these is the names are too similar. This is porcine insulin zinc suspension. This is protamine zinc insulin, and this is recombinant human insulin, but it is a protamine zinc insulin. So if you don't pay attention to the names, then you are not for sure what you're given. These do not behave the same in animals, even though they're all 40 units per mil. One animal will respond differently to one insulin compared to another. The whole point about trying to control a diabetic animal is finding the insulin that controls that patient and then sticking with that insulin and using it appropriately. So another example of problems. All right, so what's wrong with this picture? This was in the pocket of somebody. One was metoclopramide, one was euthanasia solution.
There's no label.
Never, ever, ever pull up anything and not label. Never make a bag of fluids and not label. Label at least with the ingredient and ideally the patient's name as well so that you can see where that's going. Now, what can you do about this? Well, except that if you're not paying attention and you're doing things rapidly and you're multitasking without this, even if it's labeled potentially, and you forget that you have 2 syringes in your pocket, the problem with euthanasia solution is it's so lethal you can't take it back. So what could we do?
Kill
Give
them.
it to somebody else. No, just,
We will kill them. What can we do to prevent that?
just don't use it.
Well, don't try. Okay, so just don't do it. But let's say it's happened. Let's say it's in the pockets, they're both in the pockets, this person is extremely busy, they need to dose the animal with metoclopramide, they pull it out and they give it. What can we do?
No, you discard what you pulled up.
We can, okay, except that you've got two things that you need to do, and you've got two syringes in your pocket. One is to a diagnostic test with metoclopramide, the other is you're going to euthanize the patient. You're right, the smart thing is to don't put them in the same pocket. That would be, go ahead.
But you've already pulled it up, so just discard those ones and pull up the new
So if don't discard them, you mean just throw the one away. Don't put it in the pocket. Throw the one away. I mean, they're both needed, so both the drugs are needed, just for two different patients.
But you don't know which is which, so discard those, take them out of the box.
Oh, okay,
and then
so
draw
let's
the new
assume
one.
that they were labeled. So let's say they were
okay.
labeled. So you're
Okay.
right, if I've got two syringes in there that are unlabeled, absolutely, those go in the trash, right? Well, not in the trash, they go wherever OSHA's told them to put drugs, right? Okay, so now let's assume that they're labeled, and the labels look the same, and I forget that I have two syringes in there, and I pull one out. What else can we do? We can.
Read it. Yeah.
So what we did, this happened at Texas A&M, is we started dyeing the euthanasia solution. We started, because it doesn't really make any difference, and we use
Comes
pink
in
color.
pink and blue.
And that's what they do now. Now you purchase it, and it's
I was
pink.
the blue.
It's hot pink. So you know when you have something hot pink, that patient better be doomed. That better be the right patient. Does that make sense? When you get excruciatingly busy, it's going to be amazing how easily you're going to forget what's going on. And so having these things in place to try and protect you and your patient is always a good thing. All right. So which of these can go IV?
Oh, wait. Not that. What's that one?
Which of these can go IV?
What's that? Is that propofol?
Propofol can go IV. If it is white, do not give IV.
Except for propofol.
Unless you've double checked it. To my knowledge, the only thing that is white that you can give IV is propofol. The difference between these two drugs, this has an acetate salt on it. That will embolize in your patient's lungs, and it will kill your patient if you give it IV. Propofol is white because it has lipids in there to help it penetrate. If you give it IV, no problemo. So, never give something white unless you've checked first. All right, so we've already done that. So what's wrong with this?
2 puffs. In the rectum? Wait,
One repeat before it's very wrong.
inhale 2 puffs in the rectum? How do you inhale in the rectum?
Wait for it, wait for it.
In the rectum?
Not too many inhaler devices that are designed to go rectally. Okay. Even the best of us make our mistakes. Okay, so let's transition now to adverse events that are not our fault. So there are 2 overall categories. The first one are going to be type A and the second ones are type B. Type B are bizarre, type A are augmented. And so let's start with the augmented because those are the most common. So an adverse event is one that causes harm. When we look at type A adverse events, these are generally exaggerated responses that reflect the action of the drug. If you know the drug, then you can probably pretty much predict them. And they may not be the desired action of the drug, but they are at least related to the mechanism of action. Now, the other kind of type A, which is predictable, is a toxicity. It really doesn't have anything to do with what you want the drug to do or its mechanism of action, but you know this drug has the potential for causing toxicity in certain organs. And so we'll talk about examples of each of these. Also under the expected effect, remember that therapeutic failure would probably need to be included in here, but what we're going to focus on is an exaggerated effect. So let's talk about them a little bit more in depth. When we look at the augmented or exaggerated reactions, generally there is a relationship between plasma drug concentrations and response. It's the same dose response curve you saw with Dr. Judd. It can be a primary response. This is what I wanted to use the drug for. It can be a secondary response. That's not why I'm using the drug, but I know it can do this. Or it can be the toxic effect that we talked about. Because they are related to high drug concentrations, and this may be relative. It may not be high for patient A, but it may be high for patient B. then that means they're predictable and we can avoid them. And one of the ways of doing it is, of course, avoiding overdosing. This might be relative overdosing. Let's say your patient has liver disease or renal disease. So they're predictable and they are largely avoidable. This is the 95% of those avoidable drug reactions that we see in human medicine. So let's use some examples. So, yes ma'am?
Sorry, what did you say was the secondary response?
We're about to see that. Let me use this slide to demonstrate that because it's hard to understand it until you see it. So we'll talk about propranolol. We won't talk about it much. Did Dr. Judd talk about propranolol when he talked about autonomics? Okay. So it's a non-selective beta blocker. We use it to treat rapid heart rates in cats with hypertrophic cardiomyopathy. It will slow the heart rate down. But it also, and that's through beta-1 receptors, but it will also target beta-2 receptors. Well, where are beta-2 receptors located? In the lungs, and they're responsible for bronchodilation. Now, if this cat has pulmonary edema, or let's say this cat has a little bit of bronchial asthma, if we use a beta blocker that targets beta-2, that's a secondary response. We're using propranolol to block the heart rate, beta-1, but the secondary response may be bronchoconstriction, and that may get our patient in trouble as well. It's an expected side effect. We warn the client, and we look for it because we know this drug. Okay. Does that answer your question? Second, okay. All right, so when we talk about the toxicity, so let's transition now to talking about toxic reactions. So when we look at organs that are at risk for the toxic reactions, those tend to be the organs that have higher exposure. Well, the first group of organs are going to be the portals of entry. They're the ones that are designed to keep the drugs out in the first place. And so the most common portal of entry of a drug is the gastrointestinal tract. And it's not just drugs, it's other toxins as well. That's how we give most of our drugs. The lungs, secondary. Most of the drugs we administer by the lungs are going to be inhalant anesthetics, but there are inhalant devices as well. And then a common site is the skin. Now, we don't administer many drugs via the skin, but just as an aside, the skin is such a large organ, it's constantly being exposed to toxins in the environment. We're focusing on therapeutic interactions, and so the skin, we don't have to deal with toxicity that much. So portals of entry are one group of organs that are predisposed. The other group of organs that are predisposed are the organs that are responsible for getting the drug out of the body. So remember, the body does not like drugs. It tries to keep them out, and when the drugs do get in, it tries to kick them out. And so organs of elimination are going to be responsible usually for concentrating the drug because they have to pick that drug up to get rid of it. And so that means the liver and the kidney. But many drugs actually are many organs are actually able to metabolize drugs. And so we'll see rarely some toxicities related to that. But for the liver in particular, the liver is going to be predisposed to those drugs that are metabolized to toxic reactions. So when Dr. Judd talked to you about liver metabolism, do you remember the sequela of liver metabolism? What happens when a drug is metabolized by the liver?
It's eliminated.
Decreases.
Say it again.
By
It gets conjugated, and then what? Why does the liver even mess with that?
For elimination.
Because the drug has to be made more water soluble. A lipid soluble drug will never be eliminated because it will be passively reabsorbed in the kidney. So the body says, okay, I'm going to make it water soluble, and that's what conjugation is all about. But before the drug is conjugated, what usually happens to that drug before it undergoes phase 2?
Oxidation.
It undergoes phase 1, right? And that frequently is oxidation. What's oxidation mean? Adds an oxygen. What does that do? Why would the liver bother doing that?
Makes it more polar.
It makes it more polar and therefore more amenable to phase 2. It's much easier to put that big molecule on it, right? Okay, so when phase 1 adds the oxygen, what happens to that drug? What happens to the activity of that drug? Does the drug become inactive as a general rule?
No.
It can be inactive or the same.
Okay, so let's remind ourselves, when a drug undergoes phase 1 metabolism, it can become inactive. It frequently does. It can be activated. That's what a prodrug is all about, right? A prodrug is activated. It may simply change its activity. It was active, it's still active, the metabolite is active. Is that making sense? And the fourth thing that can happen is it can be made more toxic. Because what happens when you add oxygen to a molecule? What do you make?
Free radicals?
Reactive species. You make oxygen radicals. And now I've got a liver that's busy doing what it's supposed to be doing, getting rid of these drugs that don't belong there, but it's making all these oxygen radicals. And it is setting itself up for toxicity. Some drugs worse than the other. So whenever we're talking about liver metabolism, I want you to always be aware that the sequela of liver metabolism determines the impact of liver metabolism. It may not just inactivate the drug, it may activate the drug, it may change the drug's activity from one metabolite to another, or it may make the drug more toxic. So the kidney, the only thing that, well, the kidney does some metabolism as well, but its primary concern is it's concentrating the drug, and that increases its risk for toxicity. Now, there are other organs that are at risk for toxicity, and those are organs that have high blood flow. The heart and the brain are always protected, and so they're always going to be exposed to higher exposure, higher amount of the drug. And then the last one down there is the metabolically active organs, the brain, the kidney, and the eye. What do we know about the brain and the eye as a general rule? What kind of organs do we call them? Sanctuaries. Those sanctuaries are designed to keep drugs out. And so part of the reason they don't always get in trouble is because they're very effectively protected. How are they protected? How are sanctuaries protected? Tight junctions, that's good. So what kind of drug gets into those tight junctions? If I want the drug to get into the brain, how would you characterize that drug? It's got to be lipid soluble, that's right. So what other mechanism does the brain and the eye have if a drug is lipid soluble and it does get in there? How can the drug get it out?
Efflux pumps.
Efflux pumps, that's right. So we've got to bear in mind as we're talking about toxicities, some sanctuaries may be predisposed if they're missing the efflux pump. And what breed of dog is missing efflux pumps? Collies and related breeds, right? It's not just collies, and it's not just ivermectins. Do you understand that? There's a whole host of drugs that, sorry, got my phone. There's a whole